Welcome to the UK Dementia and Palliative Care Conference 2026 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Advanced care planning in dementia, from the latest research to new practice, presented by Dr. Jenny van der Steen, MSc, PhD, FGSA, Associate Professor, Care at the End of Life with Dementia, Leiden University Medical Centre, and Senior Researcher, Radboud University Medical Centre, the Netherlands. Thanks for tuning in. Let's get started.
Advanced care planning is part of palliative care. We had discussion on when is the palliative phase, when does palliative care start in people with dementia, and there is a consensus that's from diagnosis. And what you can do at diagnosis or shortly afterwards, that's advanced care planning, because it's a part of palliative care. It is one of 11 domains that we found out with the European Association for Palliative Care Task Force. Palliative Care in Dementia was published in 2014, so a while ago already. And there's 8 care-related domains, and there is 3 more general domains. Initially, we wanted to define what is palliative care in dementia, but it was so complex that we thought we can't do that. We developed a framework with domains, and all the domains together make palliative care in dementia. And the benefit is that we can then also look at which of the domains should be a priority for research, for example, or for practice. Well, and setting care goals and advanced care planning rated very high on priority for research. That's a while ago. In the meanwhile, there's a lot more research on this topic. We started a new task force with European Association for Palliative Care because we had this definition for advanced care planning. Basically, it's for people with capacity. You can see that it's something that enables individuals, and the individual would discuss with their healthcare professionals and family caregivers. And they really explicitly excluded people without capacity. That was our next task, to develop a definition that does apply to people with dementia, specific to dementia. We said it's a process, and it is with the person with dementia, the family and the professional caregiver, and you can continue it when the person becomes unable to make their own decisions. And that's what we found very important, that it doesn't stop there. And this achieved a consensus in the study we did. That's a Delphi study. It's not necessarily about the end of life. That's what people think. Okay, it's advanced care planning, then it's about death. No, not necessarily so. It's not included in any of the definitions. And what I'm going to talk about is tell you a bit about that Delphi study we did to define advanced care planning in dementia. And we involved this time people with young onset dementia. Because in that palliative care in dementia framework I showed was for older people only. And we wanted to include the perspectives of younger people, and also that anything would apply to young onset dementia. And then next I'll tell you a bit about ERC, European Research Council project that I finished, and show you some examples of practice tools. Perhaps you know MySupport, nurse-led advanced care planning, and also show you some examples of tools, conversation starters, booklets that are helpful to encourage the people to engage in the conversation. This was the method of that Delphi study to define advanced care planning in dementia. But I can explain you the main output is a definitional framework and practice recommendations. And we started, that's a good thing in research, you try to build up on the research that's already there. So we involved the leaders of the Advanced Care Planning Delphi study more generally, and we composed a new task force, a new group, and we built upon the previous work. So both the palliative care and dementia work and the advanced care planning in general for people with capacity work. And then we also involved people with young onset dementia, not as panelists, because then they would be a minority, but I'll show you how we did that. And always, of course, you build upon existing literature. What was specific for advanced care planning and dementia? We found 3 issues, and that is that the capacity of the people with dementia, of course, declines or fluctuates, and then there's increasing difficulty in communicating with people with dementia, and there is increasing involvement of the family caregiver. So these are really specific for advanced care planning in dementia, adding layers of complexity. We visualize it in a graph. This is the 41st version of it, because it looks like it's easy to conceptualize things in a graph, but it's really difficult to do it in an understandable way. So on the y-axis is engagement and communication. And you can see that we thought the person with dementia in green, so their engagement is going down, but it fluctuates. It's not the same every day, and it could be periodically, it could be better or worse. And the part of the family increases. And around diagnosis, there's also the healthcare professional is engaged in advanced care planning. This is the ideal situation where you have a family caregiver and where the person with dementia can be involved in some way until the end. And it's also an ideal situation because there can be conversations started already before diagnosis, not particularly about dementia, and also outside a healthcare setting, so between the person and the family together in private settings. The 3 issues in green are also, perhaps you've seen that already, are integrated in this figure. And then involvement of family. So that's very particular for dementia. And then we wondered, when is it still advanced care planning? What if family is involved and the person cannot be involved, but the family knows the person and can give information actually about previous wishes? And it's still advanced care planning. When it was not advanced care planning, according to this Delphi panel of experts, who get the consensus about that, when the family does not know the wishes of the person, doesn't know about what was valuable in life to them, etc. But then still some other form of care planning is needed. And I like the work from the US of Rebecca Sudora and Susan Miller. They have conceptualized care planning as a care planning umbrella. So it's broader than advanced care planning. It also includes in-the-moment planning. And then, what if there's no family? That was raised by some panelists from the UK. They say, well, sometimes there is no family involved. And then the panel agreed that if there was at least one conversation with the person with dementia, then it's still advanced care planning. But advanced care planning is about the person, so you should, in some way, know their preferences, and if not, then it's not really advanced care planning, but some other form of care planning. So this looks all very conceptual and theoretical, and I like this work. in the morning, it was actually very clear. The people who were speaking about you need to listen to us, and George saying you shouldn't interrupt or jump in, and that's what happens that professionals do, is that they do not talk to the person, they talk to the family caregiver, and they go together to a conversation. And the caregiver came in as a companion actually leaves at being directed as the caregiver, because the person is being ignored. So that was the advice, that he should address the person with dementia directly. Because we tend to underestimate what people with dementia can still say or express if you give them time. So these are some of the recommendations, also with the consensus of that Delphi study. Listen carefully to what the person is saying and to understand them. Double check understanding, reading behavior. I think it was, I like this morning session with the conversations with the people with dementia. I think this all speaks to this and supports this. It could also be that people seem to be disengaged. People with Alzheimer's disease, they might not look you in the eyes, but still you need to try and connect with them and continue and assume that they can understand you. And also there's types with dementia like frontotemporal dementia, that people can stare at you, keep on staring, because they're less aware of social boundaries. And it could be a bit uncomfortable, so you need to consider that. And it's dementia, it's not that they don't want to speak to you. There is some ambiguity about which should you use, open-ended questions or closed questions, because closed questions can be easier at some point. So you have, it's either this or that, and that's much easier to understand than an open-ended question. While the open-ended question, of course, you can elicit more information about what the person really wants to say. So there's no golden rule for that. It depends on the situation and the understanding. And we involved people with young onset dementia in this Delphi study. So I said not as panelists, because they would be a small minority among all the other experts, professionals, family caregivers. But we interviewed them, and we did the same actually, we asked them the same what Steve asked them this morning. What's your tip for a professional? How do you want to be approached? And that was really very helpful. We asked them directly after an open-ended interview. We recorded simply what they were saying. And then we asked the panel to rate which of these did they like the most, find the most important, and which of these they found the most eye-opening. And these were among the most eye-opening for the professionals. So don't involve too many people, because it's going to be really complicated for the person with dementia to follow those people. And also you might get confused, because it looks like they're saying contradictory things. And there should be coordination of the care. And in our country, we have dementia case managers, which it's really highly valued to have one support person. And I've heard about models in the UK also testing that. And limit the number of participants in the conversation. It looks like the best that you involve all the people, so they're all involved, and they all hear what the person has to say. But that's not ideal because it's getting much more difficult to follow the conversation. They need more time, and the more people there are, the more chance they get that others take over. And they could be hesitant actually to say, stop, I want to finish, or please repeat, because I didn't understand what you said. And I can feel that hesitance, because if I'm among native speakers and they're talking really fast, sometimes I cannot follow it, but then I don't want to interrupt and hold everybody because of me. So I think that's just very understandable. You should keep that in mind. Bringing up the end of life. So advanced care planning is not necessarily about the end of life, but if people are close to the end of life, it really makes sense to bring it up. And it could be a sensitive issue. So preferably at some point you do raise preferences for end-of-life care. You shouldn't do it directly at diagnosis. This was the consensus too. And we asked the panel, so when is the right moment? Well, at least a couple of months after diagnosis. There's a lot of information, could be very emotional around diagnosis, not the right time. So you can wait and defer it to a follow-up conversation. And the panel also, they were a bit divided about bringing up the end of life themselves as a professional. Some said, you will make people anxious. Yeah, that's possible. And sometimes anxious is short-lived. We've seen that in advanced care planning and using of information booklet. But in the longer term, people may actually feel more relieved by talking about it. Or it causes depression or hopelessness, or that were concerns of the panelists. But there's also the missed opportunities if you don't do it. And then there was a panelist saying that the problem is actually that we are afraid to bring it up and start talking about it. Well, many older people, it's not new to them. They often already have considered what it would be like at the end of life, or what are their wishes or some things they really don't want to happen. They can also feel it, that their health is declining. It could be, I'm also getting older. I feel that health is declining. It may make you think about that your life is not going to last forever. Dementia is a terminal condition, and as a professional you know that, and not raising this is also could be a disservice to the person. So these were the ambiguities about bringing up the end of life in a conversation. Well, and then the answer is, of course, you need to do it in a person-centered way, so sense whether it's the right time, whether people are ready for that, to prevent emotional harm indeed. Now, readiness, that's an issue we're actually studying in research, defined as the willingness and ability to engage in advanced care planning conversation. And the intriguing thing about readiness is that you can say it's a prerequisite. You should be ready before you engage in a conversation, but it can also be an outcome. If you start a conversation, people may think and actually help them to get ready for that and to prepare. And I can show you that in our newest work. But first, I want to say that we, in this Delphi panel, we had a list of elements that could be or should be part of advanced care planning in dementia. There were 25 elements, and then we asked the panel, how many conversations do you need to address all of these elements? And the median number was 4. And that made us think, is this feasible at all? And now we've defined the optimal advanced care planning, but in practice, it may not be feasible. So we thought of other ways, actually, approaches. What if you can do it more efficiently? That if you have a good understanding of what this person needs in this situation, then you can prioritize those elements. I think also define different approaches. So this is really a contrast, is an order setting approach. That's I do not want to be hospitalized or resuscitated like that. It's more like a checklist. And the other is a goal eliciting approach. It's much more open. So looking at how are people, how do they feel about life, what's important to them, and what could be a goal of care. Now this looks complicated. It is also, it's under review. But what we've found actually is that a goal eliciting approach could help create readiness. It could help also create trust. While the other approach, order setting approach, requires, it actually asks more from the person, that they understand it, that they are ready for that already, to talk about whether they want to be hospitalized or end-of-life treatment, etc. So we think that for a first conversation, when there is no urgent medical issues, you'd better start with the goal eliciting approach, because that's more efficient. And also, it can help readiness. And then in the next conversation, you can address those medical issues, which are actually very handy to know as a professional. So I think there's a lot of work to be continued about different approaches to advanced care planning and which approach is best in what situation. And then to train professionals also to employ the right approach, to master all of those approaches. Well, it's quite something. I think there's still a lot of work to do. About those two approaches, we did a vignette study in 6 countries. We interviewed people with dementia, family caregivers, and physicians, showing them vignettes of those two approaches. So the upper one is the medical approach, the scripted order setting approach, and the lower one is the goal setting approach. So we had animation videos of some 2 minutes, and we asked them, the main question was, do you find this acceptable? Well, almost all find both approaches acceptable. There was a little preference for the goal eliciting approach in general. If they asked them to compare, then it was more often that they compared the goal eliciting approach than the order setting approach. But there were actually, it was close. So there's also different preferences among professionals, people with dementia, family caregivers. And then I will show you some tools for practice interventions. So first, the My Support study we did a couple of years ago. It's in various countries, and we have actually doing a follow-up study, preparing for a follow-up study, combining it with Namaste care, so kind of a total palliative care intervention. And that's the In Touch study. But we have already this experience with the My Support study. So it was composed of first an environmental scan. It was an intervention in nursing homes. So we would go to the nursing homes and look at what's usual practice now. So how could this be implemented best in this nursing home? And then we had external facilitators training the nursing staff, and an educational booklet. And it's been translated in quite some languages now and used in more countries. along with a question prompt list. Question prompt list gives the person and the family example questions of what they could ask the professional caregiver. And then we held 1 hour structured family conversations with the family caregiver. And this was actually successful. So far I haven't talked about anything about the evidence of effects, but there is some evidence of effects, and also for this one, a pre-post study that the family caregiver felt more certain in decision making. And we had a 1-year follow-up budget for rolling this out in the Netherlands, and then we developed a conversation with an avatar as an exercise for the nursing staff, so they could select the different answers and talk with the family caregivers and get feedback on their choice. And we also, what was helpful, just very simple cards. This is in Dutch, but very simple cards they could keep with the conversation. And it says, name the goal and explore what loved ones or the family caregivers already knows. And then some examples of what you can ask. So what are your concerns at this moment? Very simple, but that was missing, and I think this is also effective. And these are the question prompt list. We developed those in the different countries with help of family caregivers locally. And the number 1 question that was voted for was, can you tell me more about palliative care in dementia? Very general, but there's so family caregivers really want you to explain what it is. And then this is my last slide, and I think this fits very well also with what we heard this morning. I like this study a lot. It was an old study from the US, and what they did is they had research assistants not trained in advanced care planning, just a script with 4 questions. You ask the people with dementia these questions, and then you record, you just write down what you hear. Just listen and write down. And it was amazing how meaningful these answers were, even if short. If untrained research assistants can do it, I think that is a good start, actually, also for professionals. So this was indeed the result I was telling you about. So it is like planting a seed, and if you have a few of those starters or questions in mind, I think it can really help to initiate the conversation and also to sense whether somebody is ready for more.
That's it for this episode of the UK Dementia and Palliative Care Conference 2026 podcast. A huge thank you to our headline sponsor Audley, event sponsor Wallens, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.